Hi friends, today I am going to present my first case presentation. So this is a case of a 45-year-old male who came with chief complaints of tingling sensation over both feet of 14 days duration, tingling sensation of hands over of 10 days duration, and weakness of all four limbs of 10 days duration. History of present illness. To start with, patient was apparently normal 21 days back with a history of fever with chills of 4 days duration, which is high grade intermittent, associated with chills and rigors, associated with loose stools which are watery in consistency, non-foul smelling, and not associated with mucus or blood. Then associated with vomitings of 4 days duration, which are non-projectile and non-bilious. So later, symptoms relieved with taking treatment at a local hospital. Then 2 days after the recovery, patient had tingling sensation of both feet. That is, from 15 days he is having tingling sensation of both feet, and which started initially on the toes and extended in a span of 4 days to up to calf. Later started on fingers, that is after 2 days after developing tingling sensation over feet, he developed tingling sensation over his hands, which started on fingers and extended to wrist in 2 days. There is no history of numbness, no history of cotton wool sensation, no history of burning sensation, no history of pins and needle sensation. Patient is able to feel the cloths. Patient is able to differentiate heat and cold. Then complaining of weakness of both lower limbs of 10 days duration. Initially noticed weakness in the form of slipping of slippers. Later progressed and patient noticed buckling of knees, and patient is unable to get up from squatting position. Patient is unable to stand up. Initially he was able to walk with support, and now patient is unable to walk with support. That is, from the temporal evaluation from the onset of symptoms to narrate is about 10 days, when patient was unable to get up and unable to squat. So even unable to walk with support. Now history of difficulty in holding the glass, unable to mix the food, and difficulty in buttoning and unbuttoning. History of difficulty in combing the hair, raising arms above the shoulders, and difficulty in reaching the objects overhead. No history of difficulty in rolling over bed from side to side. No history of difficulty in lifting head off the pillow. No history of back pain, neck pains. No history of band-like sensation or electric shock-like sensation on bending the head. No history of loss of consciousness or altered sensorium. No history of emotional liability or behavioral disturbances. No history of seizures. No history of headache. No history of loss of smell. No history of visual disturbances. No history of difficulty in chewing and able to make bolus. No abnormal sensations over face. No history of drooling of saliva. No history of deviation of angle of mouth. No history of hearing disturbances. Patient is able to swallow the food. No nasal regurgitation. No history of difficulty in swallowing. Patient is able to shrug his shoulders, able to flex and extend the neck. No history of any bowel or bladder disturbances. No history of vaccination or dog bite. No history of spinal trauma, tick bite. No history of high risk sexual behavior. Past history, No similar complaint in the past, no history of hypertension, type 2 diabetes mellitus, coronary artery disease, cerebrovascular accident, bronchial asthma, or seizures. Personal history: takes mixed diet, he has good appetite. He is a chronic alcohol who takes 2 quarters of cheap liquor every day. He is a chronic tobacco chewer. Family history: he is born out of non-consanguineous marriage and first in the birth order. Treatment and surgical history: nil relevant. So, summary: a 45-year-old male, chronic alcoholic with preceding history of febrile illness, presented with acute symmetrical progressive ascending flaccid quadriparesis with sensory involvement in the form of tingling sensation without any bowel, bladder, cortex or cerebellar involvement. General condition and examination: patient is conscious, coherent and cooperative, oriented to time, place and person, moderately built and nourished with a span of 165.1 centimeter, height not measured as patient cannot stand up. No pallor, cyanosis, clubbing or lymphadenopathy. No neurocutaneous markers of syphilis. No external markers of tuberculosis. No peripheral nerve thickening. Pulse 90 beats per minute, regular rhythm, normal volume, normal character, all peripheral pulses felt, no radial or radiofemoral delay, no vessel wall thickening. His blood pressure is 110 by 70 mmHg, measured in right upper limb in supine position. Blood pressure is 100 by 70 mm, measured in sitting posture. Respiratory rate is 16 per minute, abdominothoracic type. No usage of accessory muscles of respiration. Temperature is 98.4 degrees 18, measured in right axilla. JVP is not raised. Systemic examination of CNS. Higher mental functions: patient is conscious, coherent, oriented to time, space and person. His immediate, recent and remote memory is intact. Speech normal. Fluency, comprehension, repetition, naming are intact. Reading and writing, as patient is illiterate, is unable to read and write. So no delusions or hallucinations. Mini mental status examination score is 26 out of 30. Cranial nerve examination: able to differentiate words normally on both sides. Visual acuity 6 by 6. Visual field is normal, full range. Color vision is normal. Fundus examination normal. Position of eyelids normal. Extraocular muscles free and full range movement present. Pupils 2.5 mm on either side, reacting to direct and indirect light reflex. Accommodation reflex intact. Sensations over face intact. Motor masseter temporalis, middle pterygoid, lateral pterygoid normal. Corneal reflexes intact. Conjunctival reflex intact. Jaws are absent. Wrinkling of forehead intact. Nasolabial fold on either side intact. Able to resist closure of eyes. Able to blow air, whistle. Able to hold air in the mouth. Taste sensation intact. Rennie's air conduction is better than bone conduction. Weber's, there is no lateralization. Position of uvula midline. Gag reflex intact. Able to shrug shoulders against resistance. Able to flex neck against resistance. No deviation of tongue and protrusion, no fasciculations or atrophy, able to move tongue in all directions. Now coming to motor system examination. Attitude, shoulders adducted, elbow extended with hips adducted and externally rotated, knees in extension, feet in plantar flexion, bulk, forearm, mid-arm circumferences 22 centimeters on either side, mid-calf circumference 26 centimeters on either side, mid-thigh circumference 37 centimeters on either side. Tone, upper limbs flaccid, lower limbs flaccid. Now power, shoulder flexors 4 by 5 on either side, shoulder extensors 4 by 5 on either side, shoulder abductors 4 by 5 on either side, adductors 4 by 5 on either side, middle or internal rotators 4 by 5, external rotators 4 by 5 on either side. Elbow flexion 4 by 5, extension 4 by 5 on either side. Supination 4 by 5, pronation 4 by 5 on either side. Wrist dorsiflexion 3 by 5 on either side. Palmar flexion 3 by 5 on either side. Hand grip 4 on either side. Hip flexion 3 by 5 on either side. Extension 3 by 5 on either side. Adduction 3 by 5 on either side. Abduction 3 by 5 on either side. Medial rotation 3 by 5 on either side. Lateral rotation 3 by 5 on either side. Knee flexion 3 by 5 on either side. Extension 3 by 5 on either side. Ankle dorsiflexion 3 by 5 on either side. Plantar flexion 3 by 5 on either side. Reflexes, superficial reflexes, corneal intact, conjunctival intact, abdominal lost, plantar bilateral mute. Deep tendon reflexes, trapezius normal, pectoral reduced, biceps absent, triceps absent, supinator absent, finger flexors absent, knee absent, ankle absent. All deep tendon reflexes are absent. Now coming to sensory system examination. Crude touch intact on either side, temperature sense intact on either side, fine touch intact on either side, pain slightly reduced up to ankle, pressure intact on either side, vibration intact on either side, joint position intact on either side, 2-point discrimination intact on either side, stereognosis intact, graphesthesia not tested as patient is illiterate. Cerebellum, finger nose test intact, normal, finger nose test normal, rebound phenomenon absent, dysdiadochokinesia absent, Romberg's not tested as patient cannot stand up. No nystagmus or titubation, autonomous nervous system normal, no signs of meningeal involvement, no skull or spine deformities or tenderness. Other system examination, CVS S1 S2 present, no murmurs. Respiratory system bilateral normal vesicular breath sounds, no added sounds. Per abdomen soft, no organomegaly. Diagnosis, this is a case of acute, progressive, symmetrical, ascending, flaccid quadriparesis with sensory involvement in the form of tingling sensation over feet and hands with no cranial nerve, autonomic, cerebellar or cortical involvement, no meningeal involvement. I am going to localize the lesion to the peripheral now. pathology being demyelination, etiology being post-viral acute inflammatory demyelinating neuropathy. So at the end of the presentation, I was asked about the grading of power and grading of reflexes, and also how to examine for tone of the muscles, how to examine for Rene's Weber's, how to examine for Weber's sign, how to examine for joint position sense, how to examine for stereognosis. And I was asked about the variants of what is the most probable diagnosis in this case. As you all know, it is GBS, and I was asked about the diagnostic criteria and grading of severity and variants of GBS, and I was asked about the length dependent neuropathy, and I was asked about the DD of this presentation, and I was asked about the treatment modalities, I said IVIG and plasmapheresis. I was asked whether which is beneficial among the two, and whether I could give them simultaneously, and what are the advantages and disadvantages, and any other modalities. And also I was asked whether steroids have any role in this case. If so, why? And if they are not useful, why? And I was asked about the presentation of large fiber neuropathy, small fiber neuropathy, length dependent neuropathy, and I was asked about the painful neuropathies and confluent neuropathy and autonomic neuropathy, and I was asked to differentiate between Miller-Fisher's GBS, Miller-Fisher's, and Brikenstoff brainstem syndrome, and these are the questions I remember. And I was asked about the OP compound induced delayed neuropathy also. Please like, share and subscribe to my channel. If you have any comments, any suggestions, please let me know, and please encourage me. Thanking you. Thanks for watching this video. Thank you.